Thanks, Jamie. So, good afternoon, everyone. If you haven't been here before, you don't know me, my name is Ashley Morgan, and I'm the director of the Substance Use Deflection Initiative, which is part of NeoMed's Criminal Justice Coordinating Center of Excellence. I'm really excited to be here with you today, and thank you for joining us. Just a little about my background. I'm a licensed professional clinical counselor with a supervising designation and a licensed independent chemical dependency counselor. And I've been in the field for about 20 years. I started in dual diagnosis residential treatment with women. I've worked in university counseling centers doing direct service, outreach, crisis intervention, in intensive outpatient and outpatient levels of care, again, doing direct service as well as program development around linkage and navigation, our jail program, specialty docket courts. Prior to my role here, I worked on a research study around the implementation of evidence-based practices to reduce opioid overdose deaths. And now I'm doing this coordinating center of excellence work. And today, what I would really like to do is look at some practical real world ways to support people who use substance use using a deflection lens and a person-centered harm reduction framework. My goal is really to focus on what works to keep people engaged and moving toward recovery. So I want to start by grounding us in something that's critical to the work that we do. People that we meet in a deflection encounter are navigating a lot of complex things, a complex mix of fear and stress. They're trying to survive. They often have a long history of being judged or dismissed, punished for their substance use. Many have had negative experiences with healthcare or treatment or the legal system. So even before we talk about change, we really have to talk about connection. And people don't engage with us because we have the right resources. They engage because they feel safe and respected, and they don't feel pressured into something that they're not ready for. So for deflection teams, that foundation of connection is the intervention that makes everything else moving forward possible. And that leads us to one of the most important realities of this work. The biggest challenge isn't always that people don't want help. It's that staying engaged can be really hard when substance use or fear or life circumstances are getting in the way. Many people that we are working with are maybe using daily just to feel okay, to avoid withdrawal. They might not have reliable transportation or a phone or even somewhere safe to sleep. They're just, again, trying to survive. There may be shame or mistrust of the systems, and sometimes we are the system, or that's how it appears to them. So remembering that everything that keeps someone connected improves outcomes is really critical. We can't help people who aren't with us. So our first goal is always to keep the door open. And it's completely understandable that sometimes we want to see, or others want to see, people stop using. We all know what that devastation related to substance use can cause. So that wish is about wanting to protect people from further harm. But when we lead with this expectation around abstinence, especially when it's right after an overdose, for example, or during a crisis, or if someone's unhoused or traumatized, the people who need us the most might start to pull away. And deflection exists because they are still using, they're struggling, they're still in crisis. So the real question is, how do we keep people safe and engaged long enough for change to even be possible? And engagement is the intervention. So readiness for change, not compliance, readiness. Readiness is the strongest predictor of change and success. So our job is to enhance readiness. Meeting people where they are doesn't necessarily mean that we support or encourage continued use. It just simply means that we're staying close enough to influence it. And in deflection work, small steps are really big wins. Getting someone to accept naloxone from you, having someone answer the door for you, having someone agree to a follow-up, or them letting you check in on them the next day. Those are all progress, and it's progress toward safety, stability, recovery, reducing harm. And so everything that we've talked about so far, meeting people where they are, enhancing readiness, supporting the change process, staying engaged, even if somebody isn't ready to stop using, all of that has a name, which is harm reduction. And I know that sometimes that phrase can feel loaded for some people, especially currently. And sometimes people associate it with things like syringe service programs or test strips or naloxone distribution, which are all vital evidence-based interventions. But harm reduction is a lot broader. And so it's not a philosophy of permissiveness. It's really a framework that guides how we engage with people. So it's about autonomy, collaboration, empathy, dignity, respect, and it's recovery oriented. Harm reduction is recovery oriented. So SAMHSA defines recovery as a process of change, a process, improving health and wellness, living a self-directed life, striving to reach your potential. So harm reduction is how we keep people safe and connected long enough for the process of change to happen. And harm reduction allows deflection teams to support people regardless of where they are or what their readiness is. It creates the conditions that are necessary for future change. And sometimes there's this strong overarching myth related to harm reduction that results in objection to it. There's a myth around or the belief that harm reduction encourages or enables use. But in reality, and based on the literature, we know that harm reduction acknowledges autonomy and builds safety until readiness increases. And remember, readiness is the biggest predictor of change and success. It increases the likelihood that someone's going to enter treatment and achieve recovery. Harm reduction reduces negative outcomes for individuals and their communities. It reaches people that conventional treatment rarely does. And harm reduction improves provider satisfaction. So not only is it better for the person, it's also better for the people that are caring for them. And when you think about it, the reality is that harm reduction embodies much more than just substance use. So we do harm reduction in our everyday lives: condoms, sunscreen, seatbelts, helmets, healthy diet, exercise, all of that is harm reduction. And so if we think about harm reduction as the what, motivational interviewing can be the how. So motivational interviewing is really a person-centered way of talking that strengthens a person's their own motivation for change. So it helps us stay in the conversation with someone without pushing or persuading or overwhelming them, especially if they're already in crisis. And the spirit of motivational interviewing is around collaboration, evocation, autonomy, and it really matches what deflection teams already do really well. They meet people where they are and they walk with them. So motivational interviewing has some guiding principles that give us practical ways to stay engaged with people. Expressing empathy, which means we're accepting people as they are and where they are. We're using reflective listening to really deepen the conversation so that we have understanding and can show understanding. We're normalizing ambivalence. We're developing discrepancy. So that means we're helping the person identify what the gap is between what they want. So things like staying alive or connecting or reconnecting with family or securing housing. So what they want versus what their use or behavior is doing to these goals. We roll with resistance. So if someone says like, these programs or resources don't help people like me, our job isn't to argue, it's to get curious. So saying something like, it sounds like past experiences with this have been disappointing. What would a helpful experience look like for you? We want to support self-efficacy. So we're highlighting the strengths without forcing positivity. We don't want to be inauthentic. We might do something, for example, like say, you've gotten yourself through a lot of situations that would overwhelm a lot of other people. And that strength is something we can really build on if you want things to look different. There's also an acronym that represents some of the basic skills we can use while practicing motivational interviewing, which is OARS. And these skills are things that you can always fall back on at any stage, in any situation. So first, we want to ask open-ended questions instead of close-ended questions. So close-ended questions are yes or no questions, like, have you overdosed before? We want to ask open-ended questions like, what's the scariest moment you've had related to your use? And a question like that opens the door for insight, for meaning, for safety planning without assuming anything. It allows for more depth in the conversation. Using affirmations and support. So, observing strengths, positives in a genuine and grounded way. Again, being authentic. People can pick up if you're bullshitting them. So, being real about how you're reflecting those things. Saying things like, "You've had a really brutal week. Thank you so much for still making time to talk with me today." Or you could say, "Making that phone call was really scary. And not only did you do it, but you followed through with setting up the appointment. You're really moving yourself forward." Reflective listening. So instead of asking a lot of questions, we're mirroring back what we've heard. So the person feels heard and understood. And so they can really kind of hear themselves more clearly, and we're using the language that they're using as well. So, for example, a reflection as someone's kind of talking through things that maybe they're ambivalent about, it might look like something like, part of you wants stability, but it sounds like also part of you feels stuck. Or it sounds like you want to get well, but withdrawal terrifies you. So these reflections show that we're listening and tracking both sides of the conversation and their ambivalence, which deepens the conversation without us having to push. And then finally, summarizing as a skill. We can use summaries to pull things together. Summaries help us check that we understood correctly, which is really important, and also helps the person hear some of the important themes of what they've said. So, summary might sound something like, "So it sounds like you're tired of feeling sick. You want to feel safer. You're open to exploring some new options as long as you don't feel pressured. Am I hearing you right? Did I get that right?" So summaries reinforce the motivation, they clarify the person's priorities, and they naturally move the conversation forward. And once we have that foundation, there's a few motivational interviewing tools that are especially helpful in deflection settings. In deflection, we're often, especially initially, seeing people in those early stages of change, which I'll talk about in just a second. But these are some strategies that help, especially in those early stages. So, a decisional balance. In this, we're exploring both sides. So, we're asking something like, what does using help you with right now? And we're also asking what's been harder because of using. So we're starting with exploring the pros, what is driving the behavior, what are they gaining, and then exploring the costs or the cons, and then summarizing it using their language. And we're not adding our own cons to the list, but we are ending with some of the costs. So that's kind of the thing that sticks in their brains as you continue the conversation. We're asking permission, which communicates respect. It reduces defensiveness. So you might say something like, "Do you mind if we talk about what helps you stay safe as you're using? Or would it be okay if I shared a few options that other people in your situation have found helpful?" Normalizing. That's really important to help people feel less alone and less ashamed. So we might say things like, "A lot of people feel torn. Using can really help in some ways, but it causes problems in other ways." Or, "Many people really feel scared about withdrawal, especially after they've had a difficult experience with it." There's something called the Columbo approach, which I'm not even sure people know the reference for that anymore. It used to be a crime show. But the idea is that we're taking this curious, puzzled stance, like we don't have all of the information, to explore discrepancies. It allows us to explore this without being confrontational. So you might say something like, "So help me understand. On one hand, it sounds like you want to avoid another close call, but then on the other hand, you're also using alone most nights. How do those two things fit together for you?" We want to evoke change talk. So this means asking questions that invites the person to imagine what change might look like. So some questions might be, "If you wanted things to look different 6 months from now, what would you hope that would look like?" Or, "If nothing changes from how things are today, what worries you the most?" Or a question like, "What's the smallest step you'd be willing to consider?" And then finally, we have a readiness ruler. So this is kind of asking on a scale of 0 to 10. We ask on a scale of 0 to 10, how ready are you to make a change in your use or whatever behavior we're talking about? Because motivational interviewing it's really for any type of change. It doesn't have to be specific to substance use. So we're asking about behavioral change. If someone says something between 0 to 3, they're likely still in that contemplation space, and we want to continue to explore their behaviors, understanding what drives this. We want to continue to build the relationship, rapport, and trust. So we could also ask a question like, if the rating is a 2, you can say, why is it a 2 and not a 0? Because maybe there's something there. For ratings between 4 and 7, there is some contemplation happening, maybe preparation. So you might say, if they say on a scale of 0 to 10, it's a 5, what would need to happen to move you from a 5 to a 6? And then if they're scoring at 8 or above, we help to identify concrete steps and supports. So with the readiness ruler, the goal is to always meet the person where they are, and then move them maybe one notch more, not all the way to the end of the ruler. And before someone takes action, we often see kind of small shifts start to happen. So you might notice less resistance, or that they aren't arguing the position as strongly. They might show some resolve. They might start offering bits of change talk or asking questions like, how does treatment work? Or what would happen if I tried something different? You might hear them envisioning a different future or experimenting with small changes. And these are all kind of signs that readiness is increasing, and that's our cue to support next steps. Now let's talk about matching interventions to a person's stage of change. We often lose people because we intervene at the wrong stage of change. That's when resistance appears. And most often resistance isn't defiance. It's really a signal that what we're doing, our approach is mismatched, that we aren't meeting people where they are. It tells us we're ahead of the person, or maybe we're imposing our own goals. So our task is to adapt and roll with resistance, not to kind of persuade or drag them along. So we want to become really familiar with the stages of change, knowing what the stage looks like, what the goal is, matching the appropriate interventions, knowing what the signs are that you can move on to the next stage of change. And often with deflection, like I said before, we're seeing people at those earlier stages, especially in those initial encounters. So starting with pre-contemplation, this means the person doesn't see a problem at all, or just isn't ready to change at all. So the goal here in this stage is all about the relationship. It means, success means that we're building this relationship. We're creating safety to be able to have some honest conversations about use, even if the person is still seeing more pros than cons. And honestly, those pros can help us understand what's driving behavior, which can be important in helping the person. So in this stage, we're focusing things on like meeting immediate needs. We're offering naloxone and other harm reduction things, and expressing curiosity about their world without pressure. And we're only moving forward when they begin to acknowledge even like the smallest downside of their current use. In contemplation, the person is starting to weigh pros and cons, but there's not a plan for change yet. So the goal is to explore ambivalence safely, not push for a decision. And so we can develop discrepancy between what their goals and values are and their current behavior. We can use tools like that decisional balance or readiness ruler to help them articulate these mixed emotions. And we can move on when they begin testing out some of those small changes. In preparation, the person intends to change, they're getting ready, and our role is to help them identify some small, realistic steps. So maybe helping them find some walk-in hours, or helping them make phone calls together, identifying options for transportation, getting an ID. And we can move on when they have a clear first step. In action, the person is actively changing their behavior. We got there, they got there. So we're reinforcing these new behaviors, supporting skill building, recovery planning, doing warm handoffs, and affirming the effort often is really important. It reinforces self-efficacy, and we can move forward once the change is sustained for 6 months. And then finally, we have maintenance. Maintenance means that the person is working to sustain change. So we might continue supporting by problem solving or strengthening or introducing new recovery supports, checking in. Checking in is how we can prevent a lapse from turning into full return to use. And then there is a relapse stage. We know that recovery isn't linear. So in this stage, the individual has returned to the previous behavior after a period of change or abstinence. It's important to know or think that relapse isn't failure. It's really data and information. And our tone and our attitude about it, which hopefully is compassionate and non-judgmental, that can really determine whether someone re-engages or disappears. And it can also determine how they frame the relapse for themselves, how they think about it. So our goal is to really normalize that this happens, to help manage any crisis that might come as a result of it, and then support re-entering the change cycle with new insights. We want to focus on what did you learn, what supports need to be in place now to move forward. So to wrap up, harm reduction isn't the opposite of recovery. It's how recovery starts. Small steps towards safety or stability matter. Those small incremental pieces are really kind of the magic. Readiness, not compliance, predicts change and success. Our job is to meet people where they are and stay with them as they make choices that support safety and connection, well-being and recovery. And we have the ability to drive this change when we use these strategies and principles. With that, there's references here, but otherwise we can take any questions if any.